Welcome, everyone. Good evening, and thank you for joining us for tonight's virtual UMiami Health Talk. The topic is men's health above and below the belt. I'm health journalist Ileana Bravo, and I'm going to be your moderator for this evening for this talk. Tonight's UMiami Health Talk, by the way, is presented by UHealth Virtual Clinics, and UHealth's expert providers are ready to care for you, whether it's in the clinic, in person, our facilities, or virtually, wherever you are. We invite you to learn more about the ways we are keeping you safe, all the measures we have in place for your protection, as well as all your appointment options by visiting uhealthvirtualclinics.org. Tonight, we're going to hear from UHealth physician expert, Dr. Bruce Kava, who will be our presenter. As I said, the topic is men's health above and below the belt. He is going to discuss the various health issues that impact men specifically, and areas with warning signs that men often ignore, disparities in men's health, and of course, the importance of communications with your healthcare provider. During the presentation, by the way, we'd like to let you know that we are going to poll the audience on questions relevant to our topic and our discussion tonight. All of your answers will be anonymous, of course, but they are a very important addition to the conversation. So we invite you to be proactive and participate with us tonight so that we can all learn together. And in addition, we're going to have a Q&A session, questions and answers that will take place at the end of the presentation to answer any of the questions that you have. Some people have submitted in advance, but if you haven't, there's plenty of time. Look at your Zoom screen now and you see the little Q&A icon box at the bottom of your screen. It has the little Q&A, questions and answers. So you can submit those questions as we are going through our presentation, and there's plenty of time for us to tee them up for our presenter tonight. So let me introduce you to Dr. Bruce Kava, who is Professor of Urology and Director of Men's Health at the University of Miami Miller School of Medicine. During his 20 years at UHealth, he has served as the Chief of Urology at the Miami Department of Veterans Affairs Medical Center, and he was the interim chairman for the Urology Department in 2010. Dr. Kava's clinical specialties include urologic cancer, sexual dysfunction, and benign prostatic hyperplasia, BPH. Now, Dr. Kava works out of the Professional Arts Center in downtown Miami, UHealth Plantation in Broward, and UHealth Boca and Boca, but these are only a few of our many UHealth locations throughout South Florida that extend from South Miami-Dade all the way up to Palm Beach. Now, tonight will be a frank and enlightening discussion, we hope, and we know that you will learn. So we encourage you to participate, to be proactive, and even feel free to include your spouse or your partner in tonight's discussion. So before we kick off our discussion tonight and introduce you to Dr. Kava, let us start with our first poll question so we can jump right into it. And please, all of you who are on with us, answer this. Have you ever had an appointment with a urologist? Yes or no? Have you ever seen a urologist as a patient? And so many of you I know are jumping on, and the answer is 78%, Dr. Kava, say yes, and 29% no. So I think this is time for me to turn it over to you. Dr. Kava, take it away.
Oh, thank you so much, Ileana. It's such a pleasure, an honor to be here tonight and talking to people about an area that I really love. My only issue, I'm trying to now negotiate this thing, and I'm not able to move my slides. Haha.
There we go.
There we go. All right, so there we go. Without further ado. So what I'd like to talk to you today about is the various gender-specific health issues that affect men above and below the waist. We'll talk about several of these issues and also discuss areas where men are notorious for ignoring certain warning signs. And I would call these missed opportunities for healthcare. We'll talk a little bit about advanced communications between patients and healthcare providers. Also, at the end, we'll talk a little bit about a strategy for pursuing men's health in terms of a checklist, as well as development of a men's health center. What I would start out by saying at the very beginning is that men approach their healthcare much differently than do women. They're very unique in the way they look at things. Women in general are wonderful health advocates for their own health. They seek care they're more likely to seek care for chronic illnesses like hypertension, osteoporosis, anxiety, back pain, arthritis, diabetes, and depression. It's funny because I was talking to a group of colleagues today at the lunchroom about the talk that I was giving tonight, and we discussed it, and everybody had something to say about this. I had an endocrine surgeon who said, "Oh, and men don't go for their thyroid checks either." And then I had we have a bariatric surgeon who's wonderful, and he said, "Oh, they don't go for their bariatric surgery as much as women do." And these can result in significant problems for men down the road, which we'll talk about tonight. One of the biggest problems that we see is an ideal or a notion that the psychologists referred to as hegemonic masculinity. And the whole notion in here in Miami, we refer to it as a machismo attitude towards healthcare. Men basically, they often equate healthcare with fitness or physical fitness. And this gives them a sense of control or self-reliance on their own health. And it gives them sometimes a false sense of security. I mean, we know that men rationalize their medical symptoms and respond in self-rated health questionnaires that they are better in their health than they actually are. But as a result of these problems that they have and their ability to actually feel or understand their own health, this results in significant delays in care. And we know that the cardiologists see this often. Many men, the first time that they experience chest pain, they actually ignore it. And they blame it on, oh, I may have had something bad to eat, or I had an upset stomach. And they kind of go on with the chest pain for a couple of days before they seek care. And that can result in significant problems with their heart. Same thing for urologists. I deal with testicular and penile cancers, which we shudder to think about sometimes. But young guys basically thinking that they're healthy would delay seeing a urologist for one of these problems, which is often very obvious when we do our exams. We know that men don't take advantage of cancer screening opportunities. Colorectal cancer, they avoid that colonoscopy. They very often will go for alternatives or not go for anything at all. Skin cancer screenings, lung cancer. There is lung cancer screening now available, and it's resulted in significant reductions in the death rate and mortality from lung cancer as a result of lung cancer screenings. And then prostate cancer, which we all know has created a tremendous controversy now about whether men should have prostate cancer screening or not. We'll hopefully touch base on some of these things a little bit later. But all I could tell you is that if women really ran the show, I think that the men would be really going for their screening examinations. The average life expectancy is generally considered a gauge for the population health. The longer you live, the healthier you are. And we've seen tremendous improvements over the years. And this diagram goes back to the 1970s. We've seen between 5 and 15-year increases in life expectancy for men and women during that period of time. If you go back to 1900, the average life expectancy, believe it or not, for a male was 47 years old. For a Black male, it was 33 years old. So we've made tremendous strides in our ability to survive, to treat illnesses, to hopefully proactively diagnose illnesses before they become problematic for people. But what we see is that men lag generally behind women, and they generally live 5 years less than women. Well, this could be a problem. I mean, this is a problem, and how do we figure out why is it that men die earlier? As a scientist, I have to go back to the data. You know, we hear every day, Dr. Fauci, going back to the data for the COVID crisis. Well, we have to deal with the scientific data that's available. Why are men dying? And that's a basic question. Why do men die? And we could see that over the various age groups, there are different causes. If we look into the older age group, 65 and older, the majority of people die of either heart disease or cancer. It's terrible to think about these things, but if you go back, also between 35 and 55 years old, the majority of people will die either of heart disease or unintentional injuries, believe it or not. These are injuries that were unexpected. Homicide is part of this, falling off. We're going to go into a whole variety of different of these unintentional injuries, but they are a major cause of mortality prematurely for men. Suicide, we'll talk about a little bit later as well. Those are the respiratory illnesses, which Many of these we'll see during the course of the talk are fully reversible if and preventable. If you live to 75 years old, between 40 and 50% of men have heart disease. Obesity, it is rampant in the United States now. 40% of men are obese. Overweight, if you want to add the overweight men with a BMI between 25 and 30, that increases that number significantly as well. And we know that obesity is associated with type 2 diabetes, heart disease, dyslipidemia, sleep apnea, osteoarthritis, and cancer, in fact. As a urologist, we know very, very commonly that we see kidney cancers, and it occurs more often in people who are overweight. We know now from some of the survivorship studies that we're doing with prostate cancer that men who are overweight recovering from prostate cancer have a higher risk of recurrence of that disease. So obesity is a major problem, and men have done a very good job, we could see, of catching up to the women. We're doing a lot with cancer these days. We've actually, early diagnosis, early detection is a wonderful thing that we've really invested tremendous amount of energy, time, and finances into. And it's done very well. We could see that these are the latest cancer statistics. And as a urologist, I see this very often because prostate, bladder, kidney cancer are right up there. Prostate cancer is the #1 diagnosed cancer in males. It's a #2 cause of death. But if we look on the screen on the right, we could see that the incidence and the mortality from cancer is actually going down. Lung and bronchus cancer. We've done there's been tremendous amount of effort gone into reducing smoking and reducing the risks related to smoking-related illnesses. So lung and bronchus cancer has gone down. Prostate cancer too has gone down with earlier detection models that we've had. I wish I could say the same for pancreatic cancer. Colorectal cancer has gone down. As the more screening, again, we talk about screening, we're learning about screening with COVID, we should be screening for cancers as well. So we talked briefly about unintentional injuries. It's kind of sad, but this is a page out of Forbes magazine. Every year they have this, the deadliest jobs in America, 2019. And we lose about 5,000 men each year during their employment. Loggers on the upper left hand of the screen, loggers have the highest incidence of death-related injuries. Fishermen, sanitation workers. This gentleman all the way in the left lower corner is fixing a roof. Roofers actually have a very high incidence of falling on roofs and creating significant amounts of morbidity and mortality from that. And as I was doing this, I just have to point this out. I looked across the street from my house. This is one of the houses across the street from me. And like out of a page of Where is Waldo, do we see there's a guy working on the roof across the street, no harness. I mean, this is, in 2020, this should not be the state of affairs in the United States. We drive too fast. So motor vehicle injuries has gone down significantly over the last couple of years. But again, males between 20 and 24 really lead the pack in this. A lot of this is related to the protections that we have in our automobiles and not necessarily better driving practices, although I hope to think that it's the opposite. Suicide last year reached the same number of people committed suicide, same number of males as died of prostate cancer. That is outrageous. Men are dying like it's a pandemic as well, suicide, not only in the United States, but across the globe. It's the 10th leading cause of death in the United States. And we're talking about 48,000 people overall, and a large number of these are men. 3 to 1 males commit suicide. And this, again, some of this relates to that hegemonic masculinity that we talked about earlier, the machismo. Men have a very limited repertoire of emotions. Most of these men that commit suicide had no outward symptoms of it. They weren't seeing a doctor like the women are seeing doctors when they're depressed. Men don't generally go to see psychologists or psychiatrists when they're depressed. And so a lot of these are hidden. And then it unfortunately comes out because of the way that they commit suicide. Much of this is it's fairly aggressive means between hangings and suffocation, things like that, where there's no turning back. It's not like taking an overdose where sometimes that patient can be rescued. None of these men commit. This is a terrible situation in the United States now. Well, I painted a bleak picture in many ways. Hopefully I didn't make it so bleak that you turn this off and say, this guy's, I'd rather watch CNN. But what I would tell you at this point is that many of the things that are killing men are fully reversible. And with modifications in our behaviors and our lifestyle choices, we can actually turn a lot of this around. These are modifiable causes for mortality for most of the things that we talked about. Smoking contributes a large degree to any of the respiratory illnesses, to heart disease, to cancers, high blood pressure, overweight, obesity, physical inactivity, sugars, sodium intake, and just our diet. These are things that are fully modifiable. And they can actually retake these recommendations from our primary care doctors. We can reverse many of the problems that we have. So with that all being said, I think if you think about men's health in a nutshell and you try to compare it to women's health, what I would say, and this is data from Australia, looking at healthcare utilization rates among all adults in this, this is the Health Improvement Network. And they looked at several million males and females, and they plotted, because they have a central registry of when they go to doctors. What we can see on the left hand of the screen is that generally men and women go to the doctors at about the same rate as pediatric patients. And then they graduate from that. They get older in their teenage years, less parental oversight, less government regulations as far as their vaccinations, things like that. And what you can see on the bottom of the screen, on that bottom graph, is the male curve, and the upper graph is the female curve. And males basically get lost until about 60. 60, 65 is when the two curves seem to merge again. So during this period of time, women are seeing the gynecologist. They're fully in tune and in check with their primary care doctors, but men have been lost until they're 60 to 65. And what are they coming for? Well, they have heart disease at this point. Many of them obese. Many have chronic pain disorders at this point that they're seeing their physicians about. Prostate, erections, and wellness. These are the main problems that men have at this age. And during that period of time, between 10 and 15 years old and 60 and 70 years old, there's been a lot of damage that could have been prevented. Well, as a urologist, you gave me the baton, and I'm going to talk about sex. I mean, I'm sorry, guys. I hope you're not, turned off by these conversations. But this is a major, as we'll talk about, is a major part of health. Not only a right based upon the World Health Organization statement about sexual health, but it is also it gives us an insight into a men's overall health status as well. This is coming out of Australia, and this mimics something we'll see in a little while coming out of the United States, looking at the relative incidence of various sexual disorders. We can see, we all think about erectile dysfunction on the lower right-hand side of the screen as being, that's in the news very often. There are many things that come out between the pills and the therapies and stuff that are available. Erectile dysfunction is certainly a major problem for men. Believe it or not, reaching climax too quickly or premature ejaculation is actually the #1 problem with sexual health for men. But interestingly enough, similar to the depression situation, similar to suicide, men do not admit to this. They don't go to doctors about these problems. There's a tremendous amount of embarrassment, humiliation. They're afraid to ask. They don't know whether it's normal or not. Many men have never actually had a discussion with their fathers, with their family members about what it's like with sexual relations and what to expect. So many of them don't really seek medical attention for premature ejaculation. Lacking interest, feeling anxious, anxiety, performance anxiety, these are also very, very significant problems for men.
So Dr. Kava, we thank you for, a refreshing and frank discussion, like I said at the beginning, because I think this is what our participants want to hear, maybe even need to hear, which is why I also encourage, partners and spouses to participate. So let's go to the poll question 2, which is, have you ever felt embarrassed to address sexual health problems with a provider? Yes or no? So have you felt embarrassed to talk about sex with your health provider? And while we're waiting for everyone to answer that, I'll remind you to send in your questions. Remember the Q&A little box at the bottom of your Zoom screen, because we want to hear from you. And with some of the female topics we've done, we got a barrage of questions, and the men are coming in slowly here to participate. And we really want Dr. Kava to answer your questions. It's important tonight. So there's the response. 60% said no. That's refreshing, but yes, 40% said yes, Dr. Kava.
Oh, that's great. Actually, that's, well, 40% is still a lot, but actually, I just got another one on my cell phone asking, you have to answer your own questions. So yes, I felt embarrassed on occasion. Okay, I'm going to admit to that too. So let's talk a little about erections, okay? And again, some of you out there in TV land may not really feel comfortable about discussing this, but these are general health problems. As urologists, I deal with this on a daily basis. This again, as we'll see in a couple of minutes, this is something that is really a marker for other disorders as well. Erections themselves is, if you go by the NIH consensus statement, the inability to achieve or maintain an erection of sufficient rigidity or duration for satisfactory sexual relations. That includes achieving and maintaining the erection, and the rigidity and the duration for satisfactory. So this encompasses, they had to make this encompass all types of sexual attitudes, behaviors, and gender preferences. If you look at the numbers, and this is data from the 1990s, this has been repeated in several other studies since then, but this is really the sentinel study showing that 50% of men between 40 and 70 have some type of erectile disorder. You can see on the graphs there, as you get older, the incidence goes up, and also the incidence of more complete or more severe erectile dysfunction goes up as well over time. When you drill this down, and again, this is the result of the male Massachusetts aging study, which is, again, this is the sentinel study and really the one that's still widely cited. And they looked at a variety of risk factors for erectile dysfunction. And this is really important because you look at age, diabetes, hypertension, HDL concentration, they weren't able to classify the total cholesterol levels or the LDLs in the study. Heart disease, smoking, and DHEA, they didn't look at testosterone, they looked at DHEA. They looked at a whole variety of medications, as well as psychological issues. And these were all associated with having an increased risk or incidence of erectile dysfunction. What puts this together? What's the common path here? Particularly on the left side of the screen between the age, diabetes, high blood pressure, heart disease, smoking. Well, it's a vascular disease, if anything else. And so you have to understand that an erection is a vascular event. This is unfortunately, you know, this is schematic, thank God, okay? So there's each of the penis has two separate areas within it, two erectile bodies as we classify them, and each has its own central artery. And from that artery, blood flows into the penis, gets trapped inside this elastic membrane, almost like a big water balloon. The balloon gets filled with water, and there's no way for the blood to get out. And we could see in the schematic on the right upper part, the flaccid penis, and then as the penis engorges with blood, there we have the erect penis as well. And again, it's the veins, which are the blue lines coming off of it. I don't know if you guys can see my arrows, but these blue lines are coming off the outside. These are draining the flaccid penis, but they're no longer here because they've been compressed. And so the compression of these veins, the inflow of blood, that causes the penis to get erect. Well, just think for a second, what happens if there's not enough blood flow going in? And that's precisely what happens to most men as they get older. The amount of blood flow, because of atherosclerotic disease and all the changes that we go through as we age, there's less delivery of blood into this penis to make it erect. So what I would say is that if you go to most doctors now, you'll complain, you'll tell them about the erectile dysfunction, and either they'll you know, doctors or many of these clinics that have sprouted up, and we'll talk about those in a little bit, but you can see them online. You can get you get them on commercials all the time, Roman and a whole variety of different ones. They have a variety of different screening questionnaires that you'll get in the mail or on the internet. basically to make sure it's safe, and they'll prescribe one of these medications, particularly the Cialis, Viagra, or Levitra on the upper left-hand side of the screen. If that doesn't work, there's a process of care that the Sexual Medicine Society has initiated, showing that we can use intracavitous injection therapies, we can use vacuum devices, and for those men that don't really respond to the others, or for men now, we can even, there's a penile implant, there's a surgery that we do that we can put in a device that allows men to get firm or hard. So we're taking a gentleman who has these potential underlying risk factors, and one way of doing this is to give them a treatment. But aren't we underscoring the problem here, or not making the problem sufficient enough of a problem? Because all we're doing is throwing a pill at somebody or giving them a treatment. The world changed for urology based upon this one article that was published in 2005. What this was erectile dysfunction, and it linked erectile dysfunction with subsequent heart disease. Okay, Ian Thompson took an entire series of patients who were enlisted in a study looking at a prostate medication. He took the placebo arm, and basically they followed these men for 7 years, the placebo, so they were given no more than a sugar pill, basically. And what he found was at time zero, if on the graph on the left side, if the men had erectile dysfunction at time zero at the beginning of the study, by 7 years at the end of the study, 11% of these men had a major cardiovascular event. That is significant. That's over a 7-year period. Major cardiovascular event is a heart attack or something similar where they were debilitated as a result of it, a massive arrhythmia, sudden death. So over a 7-year period, this changed things for us, because now we're seeing erectile dysfunction as a vascular disease and linked to cardiovascular disease. In fact, when they did the studies on they looked at 8,000 patients with this, the hazard ratio for having significant cardiovascular event if you have erectile dysfunction was 1.5%, 1.5 times that of the normal men. So we have to take this to heart, literally. We have to look at this data and we have to start thinking, well, should we just be taking a man who comes with erectile dysfunction and just giving him a therapy? Shouldn't we that's just scratching the surface. We need to dig a little bit deeper. And so now what we have basically, this is not quite across the board yet, but many of us, particularly the people who are involved in sexual medicine research and work, are looking at this as a process of care model. Because if you have no overt cardiovascular symptoms and you come in complaining about erectile dysfunction, I can tell my patients 11% of you will develop a heart attack or a major cardiovascular event in the next 7 years. So wouldn't it behoove them to look a little bit further? So what we do now, we can't throw testing. We wouldn't put everybody through an angiogram or a stress test necessarily under these circumstances, because not the false positive, but basically we'd be subjecting an awful lot of people through these tests. But what we'll do is we'll calculate a American Heart Association risk score, and we'll classify them based upon that into low or intermediate risk or high risk. If they're a high risk patient, that based upon these scores, then we'll refer them immediately to a cardiologist for further evaluation. If they're low or intermediate risk, our recommendations at this point are very often a coronary artery calcium score, which is no more than just having a non-contrast CT of the chest. And it basically can risk stratify your chances of having significant cardiovascular disease. It gives us a lot of information whether you would benefit from being put on a statin. And basically, this is opening up a door to men. They're coming to us again. Remember, they've ignored us from 15 years old to 70 or 60 years old, and now they're coming to us with erectile dysfunction. Now we're going to open them up and open up their eyes and see what's inside them that we're missing right now. It allows us now for those people that are overweight and have other risk factors, to start using some dietary manipulation. And again, this is done with our, we have a wonderful we have a whole variety of different cardiologists here who are involved in prevention or preventative cardiology. We also have our primary care doctors and our internists here are also very involved in these strategies, looking at weight loss and a variety of different dietary manipulations. Increasing your physical activity, 30 minutes of daily exercise. This is an Australian study showing significant improvement in longevity as a result of this. 12,000 men were participating in this trial. And it doesn't hurt, even if you haven't done it for years. If you start late, for those people in this study from England, again, they spelled aging study, A-G-E-I-N-G, but basically they looked at men who had been inactive for many years and then started their physical activity. Obviously, you want to check with your primary care doctor, or your cardiologist to make sure it's safe to do it at that point. But if it is safe, then go ahead and do it, because basically if you start your activity even later on in life, there's significant benefit from it. Now, this was an interesting study, and this is something that's very important, I think. The 110 men randomized with a 2-year weight reduction program who had erectile dysfunction. These were all erectile dysfunction men. They received monthly coaching and instructions as far as caloric intake, self-monitoring, food diaries, and also guidance on their level of activities. What we can see is tremendous, over a 2-year period, the fiber intake on the right-hand side of the screen, fiber intake improved, saturated fat, so they were listening. Complex carbohydrates improved. Weight, they lost 15 pounds relative to the 2 pounds that 15 kilograms versus 2, which is much more, versus the 2 kilos that the people in the control group did. Change in BMI was significant, cholesterol, glucose, and if you look at the bottom, their erectile function improved. This is amazing work, because over a 2-year period, we can show that not only will we improve your general health, we'll improve your erections as well by getting you healthier. And in fact, a variety of different, since that study, several other studies have looked at other things too, like lifestyle and exercise, Mediterranean diet, weight loss, looking at use of statins, and all of these, this is from a meta-analysis looking at this, which looks at a variety of different things, but basically showed that all of these significantly not only improved health, but they improved the erectile function. So now when I haven't been a Subway in a long time, my daughter's going back, but when she sees this on the subway walls and they're advertising, the consumerism for erectile function meds is outrageous at this point. When you see this out there, you have to say, is this really what we should be doing as doctors? Just prescribing these medications? No, we need to use this as an opportunity to investigate somebody's health. Peyronie's disease is, this is my segue into the next disorder that I want to talk to you about, because we talked about masculinity and embarrassment. Peyronie's disease is truly a debilitating disorder for many men. And what it is, the people who, sorry, I'm missing a couple of the pictures here, I apologize. But they thought it was a little too dicey to show the advertisements on TV on what this drug was. But there's a drug now, which is a collagenase enzyme, which we can inject directly into patients with Peyronie's disease. Peyronie's disease, and again, for some reason, the slide of the picture is not showing up, but it's a curvature of the penis associated with a plaque or a fibrous scar that develops on the inside of the penis. And it can cause debilitating curvature in some cases. So the companies, when they did their advertising, had to show vegetables. You'll see cucumbers, you'll see ketchup bottles, and you'll see the young guy who's getting into his Mustang convertible with a curved key, and showing how it really doesn't fit. The innuendos are great, but basically what we see in the office are guys that have really, it's an underreported disorder. Most of the studies, most of the web-based studies where men are anonymous indicate that the incidence is somewhere between 7 and 10%. So curvature associated with penile erections, which may also translate into a nodule or a plaque, also may cause erectile dysfunction. It's relatively underreported. Men are really embarrassed by this disorder. And it hasn't come out of the woodwork yet, like when Viagra, Cialis, Levitra came out, a lot of men it became normed, and it opened up doors for men to be able to discuss these issues with their doctors. But this is something that still people are not discussing outwardly. Well, we're doing a lot of work with this disorder here. Again, between 7 and 10% of men actually have the disease. It's underreported, underdiagnosed, and undertreated. We're doing a lot of surgery for this, but we have now a minimally invasive procedure which is a collagen. It's a collagenase enzyme which can break down the plaque. On the top right of the screen is actually a scar that's formed inside the right between the two corporal bodies or the erectile bodies of this penis. And we basically put a needle in here and inject a medication which breaks down that scar. We actually got a grant from the company, and this is a major initiative here, is to try and diagnose this earlier, try to detect which people would best respond to this in truly minimally invasive procedure, as opposed to having a surgical procedure to change it. I want to talk a little bit about BPH, another disorder that we see. We mentioned before erectile and sexual disorders, bringing men to the doctors after the age of 50 or 60. BPH is another one that we're seeing. And again, there have been major changes in the way we approach this disorder. One size clearly does not fit all. Not every prostate's the same size and shape. Although we used to, if you asked me 10 years ago how to treat somebody with prostate enlargement and lower urinary tract symptoms related to that, I tell them you give them either a group of medications or we do a special procedure called a TURP, which we'll talk about in a couple of minutes. And that was our armamentarium of really tried and true treatments. But now as we're expanding this considerably over time. So the prostate, as it gets larger, causes a variety of symptoms for many men. The left-hand side, it causes some men experience storage symptoms, daytime frequency, waking up at night, urgency, even urge incontinence where you can't make it to the bathroom fast enough. For some men, it translates into being a slow urinary stream, splitting or spraying, hesitancy, waiting really. If you ever go to a movie theater or a show you'll sometimes often get stuck behind the line because some of the older guys are standing in front of the toilet trying to get the urine to come out, and it can be a real problem for some people. And then you have those guys that dribble, and that's problematic for many people as well. Well, the prevalence is much higher than we would expect. Between 25 and 30% of men over 50 have moderate or severe symptoms related to this. That is significant. We talk sometimes about some of the cancers and the relative incidence. 25 to 30% of men, we're talking about multiple millions of men who have this problem. We assess it basically with this. This is something that you'll get in your doctor's office, and it looks at, this is called the International Prostate Symptom Score. And it's basically a scorecard that you get to fill out in the office. It's graded on between 0 and 5, being 5 more severe. And then it's a series of 7 questions in the quality of life index related to that. And this has been something that's been validated multiple times over, and it gives us a number. You get assigned a number indicating the severity of your symptomatology based upon this symptom score. 1 to 7 are mild symptoms, 8 to 19 is a sum indicating moderate symptoms, and 20 to 35 are severe symptoms. And moderate and severe symptomatology those are significant.
Okay, so this takes us to our transition, and the question to all of you out there is, how would you rate your current concern about prostate cancer? And we're seeing a battery of questions, doctor, of people asking what's a normal PSA score and a lot of that. So clearly it's top of the mind. So is it very concerned, somewhat concerned, or not concerned at all? Your current concern about prostate cancer. %22 said very concerned, 55% somewhat concerned, and 23% not concerned at all.
Okay. We're going to go back to prostate cancer in a couple of minutes. What we're talking about now, and again, I just want to reiterate with you guys that this is benign prostatic hyperplasia, which is much more common than prostate cancer. When we talk about it, some men would refer to it as I have an enlarged prostate, or I have voiding symptoms related to my prostate, or I have to wait at the bathroom, a whole variety of different things. That's usually related to benign prostatic hyperplasia. Prostate cancer is something different. We'll talk about it in a little while, and the PSA screening and all the tests related to that. But we'll talk about that a little bit later. But what we're talking about now is predominantly benign disorders of the prostate, which is actually much more common. So for many men, the lower urinary tract symptoms, or LUTS, we use a lot of abbreviations, LUTS, lower urinary tract symptoms, BPH, benign prostatic hyperplasia, benign prostatic obstruction is BPO. What happens if you let that go? Well, most of the time it's just worsening symptoms. and your quality of life is impacted as well. So going to the bathroom is not fun, and thinking about going to the bathroom more often than a couple of times during the day, that's not a good way to, that's not a good quality of life for most men. In some cases, it may cause urinary retention if you wait long enough. Sometimes people will develop stones in their bladder as a result of the amount of residual urine in the bladder after they finish urinating. Some men will get urinary tract infections, hydronephrosis, and then there's some people that develop blood in the urine as a result. And I have to add that you have to see the urologist, and that's probably the worst consequence for many of the guys. Again, we talked before about the problems that develop as a result of BPH if it's left untreated, and the severity of the symptoms, 8 to 9, 20 to 35. These are the symptom scores associated with moderate and severe symptomatology. And for most men, treatment is relatively straightforward. Most men will go on one of the medical therapies, and we have a whole variety of different agents. We have a group of medications called alpha blockers, terazosin, doxazosin. Some of you would know these by the brand name Flomax, uroxetral, silidocin. These are things that that are very common medications. These are among the most common medications. Then we have a group of drugs called the 5-alpha reductase inhibitors, finasteride and dutasteride, which are out there, and they've also been marketed in the past as prostate cancer prevention agents. We'll talk a little bit about that. Then there's tadalafil, which is Cialis. That's the brand name. Cialis has been shown, interestingly enough, not only to impact the erections for men, but also to improve their lower urinary tract symptoms. A variety of different medications are used to affect the bladder as well, and that would include the anticholinergic agents and the beta-3 agonists, as well as combinations of these. Well, most men will go on one of these agents, and most men will do very well. But about 35 to 40% of men will either not tolerate the medication, progress beyond what the medication is doing for them, and get worse, even though they're on the medication over time. Remember, these are medications that are given to men when the symptoms start and when they become bothersome to them. But these are medications that go on for many years in some cases. So some men become intolerant to them. The symptoms progress, and sometimes they have side effects from them. And in certain cases, then surgical therapy is indicated. The standard way of treating benign prostatic hyperplasia is something called a TURP, which I mentioned before. It's called a transurethral resection of the prostate. And it's done in an operating room setting. And you can see in the middle portion of the screen on the lower part, there's a gentleman who's performing a transurethral resection. He has a telescope in his hand. It's a telescopic procedure, so it is minimally invasive. There's no incision on the outside, and basically on the upper portion, in the mid portion of your screen there, you see what it looks like when you look inside the prostate. And you can see these lobes that are sitting there preventing the telescope from going into the bladder. Well, those can be scraped out, so to speak. It's almost like peeling an apple from the inside out and working your way out to the shell. You're starting from the inside and working your way out. It's a very nice procedure. This has been really the gold standard for any treatment in urology for BPH. And the outcome data is absolutely phenomenal as far as the urinary flow rate afterwards. The men are able to empty their bladders much more completely, and their symptom scores improve significantly. In some cases, we've seen reduction of the symptom scores from somebody who's had severe symptoms. You can see 150% reversal in the symptom scores as a result of this procedure. And so it's really been touted as the gold standard. Very few retreatment rates. We've had many upgrades as far as the technology goes. But what I would say is it does require a general anesthetic. There is an overnight stay usually. Men usually have to have a catheter in place for a couple of days afterwards. And so many men are turned off by that. They have very busy lives. Their symptoms are not severe enough that they would want to consider something like this. It is a wonderful procedure, though, with very few real complications. But in some cases, certainly you have to speak to your specific urologist about these and ask their specific experience about doing these procedures. Well, these days, all of medicine is going towards minimally invasive approaches, whether it's laparoscopy or robotic surgery. Well, we have a variety of different minimally invasive surgeries for BPH as well. And what they do is they have to be effective. They have to, these are the wish list, so to speak, of a minimally invasive surgery. It's got to be minimally invasive, but it's got to be effective and durable. You have to have safety associated with it. Don't want to have anybody bleeding. Transfusion risk should be close to zero. And you don't want people to develop scars or incontinence. You want to preserve erections and ejaculation. The one problem with the TURP that I mentioned before is that very often afterwards, men don't experience ejaculation. They have orgasm, but not a lot of fluid comes out, and that's bothersome to some men. And it's enough of a barrier for some men not to have a procedure when in fact they have significant or severe lower urinary tract symptoms. Some of these minimally invasive surgeries are done with local anesthetic, and as a result, their convalescence is much, much better. I mean, it reduces or eliminates the hospital stay altogether. Many of them don't require a catheter afterwards, and it allows for rapid return to work and their activities. And what I've done here, this is the minimally invasive surgical therapy menu in 2020. What I would tell you is over the last 50 years, we've all been pursuing minimally invasive procedures or options to substitute for the TURP. TURP, again, it's a wonderful procedure, works well, but it's not for everybody. So we've been looking, and there have been a variety of different procedures that have come and gone. And many people have heard about microwave therapy. Many people have heard about prostatic stents. There are a variety of things and a variety of different laser therapies that have come and gone over the years. Most of them were not proven to be durable, and that's the difference. The ones that we have now and the way we've investigated these is so much better than we did the original group of technologies that were out there. What we see on the right upper portion of the screen is a laser. It's a laser fiber. This is called the green light laser procedure. And basically what you can do is you can basically completely laser ablate an entire prostate with this. There's less bleeding involved, less of a convalescence. Many of the men don't require a catheter for more than a day. Many of them go home the same day. So this is an upgrade over the standard TURP. And the outcome data for selective individuals, again, what I'm going to tell you is that any of these things is not for everybody. And that's what I meant by saying one size is not for all. And that's why you need to see a urologist about these things. So the green light laser is out there. The one on the left upper part of the screen. I love this procedure is a fantastic addition that we have. We just started doing this here about a year ago at the University of Miami, and we've had really tremendous outcomes with this. This is called the resume procedure. What it is steam is emitted from a little bar that's deployed through this handpiece. Goes into the prostate, and the steam stays in the confines of the prostate, destroying the prostate tissue underneath, but not going out beyond the prostate's limits. So erectile dysfunction is not effective. The risk of having the ejaculatory problems with the TURP, it's less than 2%. It's absolutely fantastic. The recovery, about a 2-week period where you're not quite up there yet, but again, you can do most of your activities during that period of 2 weeks. But most of the people by about 4 to 6 weeks after the procedure are really touting it as a major improvement. And by 3 and 6 months later, they have almost similar results as the TURP. The one on the left lower part of the screen, that's called the UroLift. That's another minimally invasive procedure where little alloys or little implants are deployed in the prostate, pulling open the lobes. This is also the effect of this on sexual function is marked improvement, and the results of the convalescent associated with this are very, very good as well. And then we have the newcomer on the right in the middle of the screen is the aquablation, which is basically it's a sonic pulse that goes into the prostate, and it actually destroys the prostate tissue. It's almost like a water jet that comes out of this. And it's absolutely incredible what can be done. It's programmed robotically, so you can actually, it's really precise. So these are things that are out there now to really help men with BPH. And what I could tell you is medical therapy is usually the mainstay of most of people's therapies, but when you progress, really we have a lot of different options for people. And actually, the latest, this is from the American Urological Association, looking at, again, not everybody one size fits all, but based upon the size of the prostate, really you have a variety of different options. For the people with smaller prostates, they generally have just a tremendous number of options other than the TURP. And then the average prostate, people with larger prostates are sometimes problematic, and larger prostates meaning about 100, 150 grams or greater. And those people have basically, they have a couple of different options. But again, this is the whole which is being done right now. We have one of the world experts on HoLEP here at the University of Miami. And basically what it is a laser enucleation for people with larger prostates. And it is absolutely fantastic. You don't need a surgical procedure anymore where there's an incision made. You can do this totally endoscopically. Just of note, I want to brag about him because less than 4% of urologists know how to do that procedure. So what I would say is that we talked about a variety of disorders. There's a men's health checklist. The urologic orders really, if we think as just as a urologist would, if we think as a urologist would think towards just the pathology related to the urinary tract, I think we're doing our patients a disservice. I think we have to think more and look more deeper than just looking at the surface of the genitourinary tract. So the American Urologic Association has come out with basically a schedule for various different types of health and urologic related milestones that men should go through. And this really starts even at the younger ages. Men should not necessarily need to see a urologist, but their primary care doctor should be helping them. And if there's a urologic issue, such as varicoceles, such as a reproductive problem, such as something else that doesn't quite match with the current standards for a primary care doctor, a referral to a urologist is really important. Even then in their 40s, 50s, and 70s and above, the urologists really have a tremendous, result in tremendous improvements in quality of life. The cancer screenings, again, we talked about this before. It's important for men to undergo these cancer screenings and not hide behind under a rock trying to avoid them. They are not, most of these are not problematic. Colorectal cancer screening for those smokers, lung cancer screening. Prostate cancer has become contentious these days. What I would tell you is that PSA is still alive and very much, very, very important in men's health. There have been some naysayers. There have been people that have questioned the role of the PSA test. It's not perfect. It does detect prostate cancer much earlier than the way that it was done. Again, I was in practice in the late 80s, and we didn't have the PSA screening available at that time. And most men presented with advanced stages of disease. PSA has changed that. So it's done a tremendous job for males, for men's health in general. It's not perfect though. And we have a variety of different things that we're offering here at the University of Miami, in addition to the PSA test itself. We have a variety of different subsets of the PSA test, like a free and total PSA. We use a 4K score, which actually our chairman and Dr. Poonen actually have published extensively on these tests, which have really changed, they're game changers in prostate cancer screening. We're using MRI to do targeted fusion biopsies often. So again, these are indiscriminate use of PSA we would advise against, but PSA screening, when it's discussed with patients, again, it's a discussion that we have based on the patient's preferences, their overall values, and the doctor's educational experience with the various testing and stuff. This is called shared decision, and that's what should be done under all these circumstances. So it's not just going to a doctor, having your prostate checked and having a blood test anymore. It's really a discussion whether this should be done or not. We have 5.6 million people in South Florida. Half of these are men. And if you look at the numbers here, this is the census data, the majority of the men are between the 30 and 50 years old. So it's not just an elderly community here anymore. We have a tremendous number of people who are young. And as they get older, we want to try to entice them to come to see their doctors earlier. Don't let what the Australian experience had happen to American males.
I think we're going to skip this poll question simply because Dr. Kava asked and you shall receive. We have a barrage of questions, which we're so happy about because people are engaged with your conversation. And we'd like to go, have you wrap up so we can go right to the Q&A if that's possible. So let's skip.
I'm going to go right to the upshot. What I would say is that I just showed during these slides just a variety of sex clinics that are out there under the rubric of men's health clinics. And I have to say, this is not what we should be looking for in South Florida for our healthcare. This is the model that we're trying to seek here at the University of Miami, a true multidisciplinary men's center to provide state-of-the-art multidisciplinary care to men 18 years and older. Evidence-based programs for prevention, detection, and maintenance of male wellness above and below the waist. There are technologies that are out there a whole variety of things I couldn't even mention in the time limits that I'm giving you today that we're even doing that we're doing in urology that I haven't even touched base on, looking at erectile disorders, looking at rejuvenation and and prevention of these things. Opportunities for education with healthcare providers as well as the patients itself, so that we can send the word out to other healthcare systems that this is what we should be doing. So what I would encourage you to do, we need advocacy on the men's side as well. This is an article that I published with Dr. Ramasamy and Dr. Masterson last year, looking at the number of people that are denied medical benefits based upon their male status. And so this is where I'm going to end it today. I think that we do need a men's health center here at the University of Miami. I think that we need the male advocacy. We need the center to really control men's health and to offer a multidimensional, multidisciplinary approach. So I'm going to stop there. Thank you very much, Eliana.
Amazing, Dr. Kava. Thank you. And again, I think people are engaged just judging from the questions. So let me start with a bunch because they need to know. So here's a combo of questions. One says, can ED be treated naturally without drugs? And that dovetails to, what are your thoughts about the high focus sound waves for ED?
Okay, so let me just start by saying, I showed at the beginning of the slides earlier that if you change your lifestyle modification, can have a significant improvement in erectile function. So we know that. Let's start with that. So lifestyle modifications, that's where everybody should start, okay? Losing the weight, getting more physically active, watching your diet, and that will not only translate into better health, but also better erections. Again, looking at a variety of different things that are out there. We have the pills, the ED medications, we have the injectables. Now, some of the areas now that we're looking at, and we have a whole group here that we're studying these investigational modalities. So the shockwave treatment is, it encompasses a whole variety of different treatments that people are touting and advertising. Commercialism has really taken hold of the erectile function market. And look, again, we talked about hegemonic masculinity. Men are a vulnerable group, especially when they're suffering a problem like erection problems. And so they see an advertisement for a modality such as low shockwave treatments, low intensity shockwave treatments, and they see that the data look convincing. And there is data out there saying that it looks promising. But the problem is that there are so many different people using different types of machines. Many of these aren't even shockwave treatments. Some of them are sonic treatments. Some of them are radial treatments. These don't have, there's no data on any of this stuff, or no evidence to show that it works. And so for $2,000 to $5,000, you're investing in these things. There's no data to support that many of them work. There is some data supporting low intensity shockwave does work in a select group of people. We're doing studies here at the University of Miami looking at different types of programs, different ways of administering it, different treatment schedules to see whether we can really do that. And we have a randomized clinical trial that we're undergoing right now. We also have some other trials looking at the P shot, the Priapus shot, looking at stem cells. People are going for stem cell implants in their penises. Again, this is off-label use. It may be FDA approved, but not specifically for erectile dysfunction. And so that's a big problem. It's almost become a wild west out there. What I would say is be very careful. When you're going to a doctor and he's recommending these things, just examine. You can't rely on testimonials to tell you whether something works or not, because these testimonials can be rigged as well. There's no way to do it. The only way to do it is look at the evidence in the literature, have a urologist at an academic center like this who's participated and actively involved in research. And they can tell you objectively whether these things really work or not.
Dr. Kava, this gentleman is asking about the treatment of ultrasound to improve penis blood flow. What about that?
Shockwave treatment is what we know is available that seems to work in specific schedules and specific wavelengths. There's no data at this point other than testimonials in our literature, and nothing by the Sexual Medicine Society of North America has approved related to ultrasound therapy.
Now, here are some very frank, personal questions that are coming from men who are saying, is it normal for men's penis size to diminish with age? The same for testicles. Is this something that you can address?
A lot of people do have that complaint that as they get older, their penis size goes down. The average penis size, believe it or not, is about 12.5 centimeters for American males. And so that's about 5.5 inches or so. Now, what you see with the penis is basically you're seeing the outside of it. There's also a part of it that's on the inside that you don't see. That's attached to the bones on the inside. A lot of the men that we see with penises that are getting shorter or perceived as being shorter, a lot of this is from their weight. As men get older, the adipose tissue deposits in the infrapubic area, just the area just above the penis and below the pelvic bones. So that can cause what we call a buried penis, basically. And there are ways to restore this. There are certain types of surgical therapies that we do on occasion with our plastic surgery team to restore this, but it's not for everybody. What I recommend for most of you with concerns about this is to see the urologist, and they can advise you about this, whether you're a candidate for these procedures and what can be done. But again, healthy lifestyle modifications are really the best bet with this. And this is an area that needs to be investigated a little bit closer.
So your take-home message is really quite powerful, and that is to say it's not just about popping pills. The fact that there's a relationship with cardiovascular disease and erectile dysfunction, you're saying this is how men should be addressing it.
If we don't think about that, we're doing a tremendous disservice. Again, I think about that subway car. I think it's amusing that that's where they advertise, but that's not what this is about. And if I went into medicine just to prescribe a pill, we don't need professionals doing that, unless we're looking at specific side effects from the medications. But we do need professionals to think beyond the level that superficial level of just giving a therapy.
And the message to men of benign prostate disease and the fact that it is part of the aging process. I see a lot of the questions from them there as well. What's the most empowering message you can give them there?
What I would say is that many men have this. We don't talk about it very often. This is, again, one of those parts of life. I know, from my experience with female patients, my wife, and I see, women tend to discuss their healthcare problems. Men don't seem to do that. And so the men that have this issue, many of them, they're kind of embarrassed, some of them. Some of them come in when they've had these problems for years, and then they take something like a cold remedy, which actually lowers your bladder's ability to empty. It reduces the power of the bladder, so to speak. Cold remedies, sometimes an alcoholic beverage that'll, again, just relax them enough so that they suddenly start retaining urine. And this is a problem. So what I would say is that you should, if you're having symptoms, you should see the urologist, or very often the primary care doctors can handle a lot of these things, but the urologist really has a full armamentarium of treatment options. It doesn't always have to be a pill next to help restore some of the symptoms. Very often we have some of these minimally invasive surgeries too, that some of the men would prefer over having a medication which is lifelong.
So we could go on and on, couldn't we? And I think that the take-home message you've made very strongly, and that is that you have to take matters into your own hands. You have to be a proactive patient with your medical care provider and speak up and tell the truth, because being in denial is not going to get us anywhere, right, Dr. Kava?
Yes, absolutely. Absolutely.
Well, thank you so much. It was incredibly informative, educational, and refreshing, because I think you have this wonderful way of speaking in a folksy manner to patients that they felt very comfortable. And we want to thank all of you out there who participated, because the Zoom screen is still full. No one jumped off. So thank you, Dr. Kava.
Well, thank you all for listening. I really appreciate it. And certainly that we have many more opportunities for these things to discuss other issues. I've just scratched the surface. Yeah. So I thank you very much for having me. I thank you, Health. I thank all the people that are involved in putting this together. This is amazing. And during the period of COVID, since not everybody is comfortable coming out, I'm glad that I can come to you guys.
Yes, thank you very much. And the UHealth communications team was incredible in putting all of this together. And again, we want to remind you that this is all videotaped and recorded. So give us a week and you'll be able to watch it on our UHealth YouTube channel. We'll send follow-up emails to all of you, so you'll be able to participate in. And again, I remind you that you should visit umiamihealth.org to learn more about how you could be seen, whether it's in person person, whether it's virtual, however you're comfortable at this stage, because COVID world is a different world. But I know I thoroughly enjoyed tonight's UMiami Health Talk, and we hope you did too. Please complete the survey at the end of it. It helps us understand the topics that you want. Give us feedback on your experience, and we'll continue to bring more and more of these to you. Dr. Kava, good night. All of you out there, stay safe and be well until the next time we see you all. Good night.
Be well, everybody. Thank you.